Amazing. Welcome, everyone. Hello. Good morning, good evening, depending where you're calling in from today. Thank you for joining us for this 7th webinar session of our Engaging with Evidence series. My name is Laura Bontsfair, and I'm Communications and Engagement Officer at the Government Outcomes Lab. And together with my colleague Andrea Anastasiou, we'll be hosting today's session. We are really excited about today's session. We have an outstanding lineup of guest speakers joining us to discuss results and key learnings from the delivery of the Kangaroo Mothercare Development Impact Bond, or KMC DIB, and we'll be exploring what this might tell us about the potential to use outcomes-based approaches to introduce and scale social interventions. For those of you who are new to the Government Outcomes Lab or who haven't attended previous Engaging with Evidence sessions, we are a small research and policy centre based at the University of Oxford. We do research around the evidence of use of outcomes-based contracting. We look at innovative financing models like social impact bonds, outcomes funds. Alongside our research, we also run a multifaceted programme of engagement and capacity building. So we always want to find ways to ensure that the insights that we generate and those around the world are generating are made accessible and can be used in policy and practice. That is why we launched the Engaging with Evidence series. So this January, we launched the series as a platform for practitioners, researchers, and policymakers around the world to come together and engage in the latest findings in the field. Our next session, which is coming up on the 28th of October, we'll be looking at how the use of outcomes contracting could foster cross-sector collaborations to improve social outcomes. We'll be drawing on GoLab's latest report on the Kirklees Integrated Support Service Social Impact Bond, which aims to support vulnerable adults living independently. We like to keep these sessions interactive, so please do use the chat to ask questions, share your reflections, and connect with others. People in the past have really enjoyed the networking element, so do please make use of that if you like. We will also be pausing at various points through this session to bring in questions or comments from participants, so please feel free to raise your hand or put anything in the chat. Today, we're going to follow a similar structure to other sessions, so we're going to begin with a few presentations, followed by a panel discussion. For the first presentation, we'll be hearing the overview of the KMC DIB, which was launched in February 2019 to improve neonatal health outcomes across 10 hospitals in Cameroon. Then we'll be hearing the government perspective of the DIB programme. Unfortunately, the Secretary General of the Ministry of Public Health can no longer make it today, but we are absolutely delighted to have Martine Ba from the Ministry of Public Health on the line, who is coordinator of the national programme to combat maternal, newborn and child mortality in Cameroon. Bienvenue Martina, nous sommes ravis de vous accueillir aujourd'hui. Following this, we'll be hearing some of the results and the key findings from the end of programme report. For the second part of the session, I will then pass on to Andrea, who will be moderating a discussion with a diverse range of experts, including the key stakeholders of the KMC DIB. We'll be hearing from Caroline Kwok from Grand Challenges Canada, from Hortense Mangeot, from the Country Programme Director of the DIB Programme, Louise Saville, Director of Social Finance, Dr. Martine Ba from the Ministry of Public Health Cameroon. We'll get an academic perspective from Dr. Mara Aeldi at the Government Outcomes Lab, and we'll be hearing from senior economist at the World Bank, Dr. Tom Kenyon. Before we hear from the speakers, we would love to hear who is joining us from today. So please do pop in the chat, say hello, feel free to let us know where you're joining in from, anywhere around the world, and do drop any questions you hope to see addressed today. Final thing is we do love to see everyone's faces, so please do keep your cameras on if possible. And just a reminder to also stay muted, just to let other people, just while other people are talking. We will also be recording the session, so we will be posting the YouTube on our YouTube and GoLab website after this of the recording. So without further ado, I think I'm going to hand over to Hortense for the overview of the DIB. So Hortense, before you start, if you don't mind just briefly introducing yourself, that would be great. Over to you.
Thank you very much, Laura, and hello to everyone joining from different parts of the world. I am Hortense Mangeot, the Country Programme Director for the Kangaroo Mothercare Development Impact Bond project. And we've been running this program, as Laura said, since February 2019. So I'm just thinking, all right, good. So Very excited to be here today, joining the rest of the stakeholders to speak about this program that we've all been very involved in, and happy to be part of this session so that we can share with you all how we have been able to work with our partners to deliver on this development impact bond. So I'd like to say that the purpose for this impact bond was to address the challenges that are linked to the high neonatal mortality rates. From our statistics, we have low birth weight and preterm births as the cause of about 50% of the cause of death among children under the age of 5. Cameroon happens to be one of those countries with very high neonatal mortality rates of about 26 per 1,000 live births. And so the government of Cameroon, with different partners, thought that there was a need to focus on how to bring down this neonatal mortality rate in an approach that is scalable and adaptable to the context. So with this challenge, what was the different partners thought that the Kangaroo mother care was a good intervention because it has been proven to be a good practice for babies that are born small or too early. We have had the opportunity to work with Kangaroo Foundation Colombia, where most of the evidence around KMC has been researched and proven. And we also find that as well as the rest of the stakeholders that Kangaroo mother care, it significantly reduces infant mortality, unlike the incubator, which of course doesn't eliminate the use of the incubator, but we found that this was quite brought significant benefits to the babies and the mothers, especially in a context where there's low resource like Cameroon. So just for a gentle reminder for those who know and for those who don't, Kangaroo mother care is built around 3 pillars. There's a Kangaroo position, which is skin-to-skin care between the caregiver and the baby. There's Kangaroo nutrition, which is the promotion of exclusive breastfeeding, given the benefits of exclusive breastfeeding, especially for babies that are born too early or with low birth weight. And of course, Kangaroo mother care enables early discharge from hospitals. And this is, again, only if the family meets the requirement to go home early to continue Kangaroo in the community. Then it helps the babies to be able to go home early, but then they have to come back for follow-up appointments right up until their 40th week gestational age. So these are the 3 pillars of Kangaroo mother care. So to speak about the structure of the KMC DIB, we are happy to have Grand Challenge here that acted as the investor for this program. They were able to provide upfront capital for the program. And then with the upfront capital, this was then put into Kangaroo Foundation Cameroon for the implementation of the project, with of course support from Kangaroo Colombia. The evaluator for this program was Iresco, that had to go to the hospitals every quarter to ensure that the data that the results that we're submitting made the quality of the work that was on the field. And of course, based on the outcomes that have been delivered, we had the government of Cameroon and Nutrition International as outcomes donors. We also have social finance that played the role of the performance management advisor, and then they were able to guide the rest of the program implementation team from Foundation Kangaroo Cameroon, and the different stakeholders to make sure to support us in ensuring the delivery of the program, as well as understanding all the nitty-gritties of a development impact bond project. So the government of Cameroon found that the development impact bond was a safe way, a low risk measure to deliver this program. And that is because the government of Cameroon only had to pay for the outcomes. So they felt secure that their funding their funds would be well spent because they only go to pay for outcomes. So in this case, based on their interest in reducing neonatal mortality, they were also looking at alternative ways of delivering, reducing neonatal mortality. And this was possible with the DIB. So the government of Cameroon was quite comfortable investing or being a partner of the DIB. Over to Nutrition International, that have a key focus on exclusive breastfeeding. And Nutrition International were able to support us as an outcomes donor, but also to pay for the evaluation sessions. So we're very happy to see that throughout the delivery of the program was able to see over 80% of mothers exclusively breastfeeding their babies up until their 40th week gestational age. And we found that more mothers were even able to do exclusive breastfeeding even beyond the 40 weeks. And we have recorded data to prove that for those who do not do exclusive breastfeeding, it was recorded why the mothers were not exclusively, why the babies were not exclusively breastfed. So this brought up the numbers of babies that were exclusively breastfed from our previous records. So the Kangaroo Foundation in Cameroon had previously been working on KMC, and Grand Challenge Canada was able to fund a pilot before this impact bond, which proved the effectiveness of kangaroo mother care in over 5 hospitals. But then there was a need to, with the use of a DIB, to ensure that the funding was flexible enough to address some of the issues that had presented themselves in terms of the context and ensuring that this is scalable. And so this did give us opportunity to test new things in different hospitals, because the combination of the 10 hospitals that we work with, we had district hospitals, regional hospitals, and central hospitals. So this did help us to be able to try new things. And with the work that social finance has done in terms of the lessons learned, we're able to learn different things at different levels, which of course is informing the strategy of the national scale for KMC going forward. So Kangaroo Foundation was very happy to be on this level of the Kangaroo mother care implementation, but of course it gave us opportunity to do a bit more than what a grant would do. So Grand Challenge Canada, within their strategy of empowering innovations, switched from a grant, going from a grant to an investor. And this, of course, was possible because they had invested in a grant before and they saw the effectiveness of KMC in our context. And they thought that this was a good approach to able to try KMC train-of-trainer model, and also make sure that it is adapted, and to also ensure that about skill, we have learned a lot of lessons. So through the investment of Grand Challenge Canada, we're able to begin they gave us the operating capital for the program, and then I'm happy to say that they also gave us opportunity to recycle the funds in the second year of the program. And we're also happy to say that we are on the 29th of September. The foundation is in the process of repaying this investment with the return. So what have we achieved? We want to just say that 10 hospitals were equipped to deliver quality KMC. We plan to equip 10 hospitals. We were able to go through the 10 hospitals at different times, given the different challenges that we had. We were able to train 47 clinicians, so doctors, nurses, psychologists, physiotherapists. We're able to also train a handful of clinicians to be able to train others, given that we might not always have funding to continue to move people from one place to another, but then the government should have trainers within their system. And because of the challenge we have with referrals or transfer of babies from the point of delivery to the point of care, we were able to train over 121 community health workers to be able to transfer the babies safely in kangaroo position. And we saw that the babies that were being transferred in the rider kangaroo position reached the hospitals with better conditions and better chances of survival. So in terms of the neonatal outcomes for the general achievement, we were able to have over 1,221 babies confirmed to have received quality KMC based on the verification. But it's good to say that generally the access was provided to over 5,000 babies. We have on our data system over 5,000 babies that benefited from this program. like I said before, in terms of exclusive breastfeeding, we have data supporting the points that we are proving here in terms of the percentage of mothers who exclusively breastfed their babies right up until the point of discharge. So we had 80%, which was a big leap from the previous call from the pilot. And then we also, in terms of the number of babies that reach appropriate weight, again, at 40 weeks of gestational age, we have over 80%. So this, of course, is for the babies that were able to come back for their follow-up appointments right up until 40 weeks. So thank you very much. I'll hand over to Laura.
Amazing. Thank you so much, Hortense. Thank you for such an insightful presentation. It's so interesting as well to see all of these outcomes achieved in just 2 years. So thank you very much for that. We have a couple minutes, so if anyone would like to ask any questions, do feel free to raise your hand. Not seeing any hands up at the moment, but I know we have a really exciting presentation coming up, so I think I'm going to give the floor over to Martina now to hear the government perspective on the DIB. So Martina, if you first just like to introduce yourself, that would be amazing. Thanks.
Thank you. Hello, everyone. So I am Martine Ba, a public health physician, presently working with the Ministry of Health in coordinating the national program to combat maternal, newborn, and child mortality in my country. So I'm glad to be here to replace the Secretary General who normally had to make these remarks, but he had a family issue, so he couldn't attend last minute. So just to say, as Hortense already stated a while ago, neonatal or newborn mortality is still a huge problem in Cameroon. Out of all the babies that die before the age of 1 year, 50% of these babies die, during the first month of life, and they represent about 28,000 babies that we're losing each year. So we realized that something serious needed to be done about this, and that's why, taking into account this high burden, we decided to implement this high-quality kangaroo mother care in the health system with the ambition of contributing to actually significantly reducing the rate of neonatal mortality as embedded in our health sector strategy that covers the period 2016-2027. Why did we support, or why were we interested in the DIB? After taking the decision to scale up kangaroo mother care in the system, and in order to put all the chances of success on our side, we opted for the approach, where you pay for results. And obviously, to do this, someone must agree to take the risk of investing before being reimbursed if the expected results are achieved, or losing their investment if the results are not achieved. So at this stage, I would like to really acknowledge Grand Challenges Canada for their readiness to take up this role of investing and pre-financing the project. How did we work with other stakeholders to design the program and ensure sustainability beyond the life of the DIB? That's where we really want to thank Social Finance here. It should be noted that the Ministry of Public Health has been at the forefront of the design and implementation of the KMC DIB. And this was, of course, motivated by the ambition to really scale up KMC as a means and scale it up sustainably as a means to reduce neonatal mortality. So the ministry ensured effective leadership, notably by chairing all the preparatory meetings. I can't count the number of times that Dominique, who was then at Social Finance, came to Cameroon, and we held all these meetings under the leadership of the ministry. So the ministry therefore ensured this leadership by chairing all the preparatory meetings and by putting in place a technical committee for close follow-up of implementation. And so the actors were constantly reminded of the importance of thinking and planning beyond the project. From our perspective, the implementation of the program has been quite successful, as we just followed the results presented by the project director, Hortense. It has been a very positive and fruitful project, which actually show how quality, I insist on the term quality KMC can contribute to reducing newborn mortality. And finally, regarding plans to extend this service beyond the DIB, we're very keen on taking up from where the project has ended. We'll talk more about this during the panel discussion, but let me just say here that we'll enroll all our regional hospitals so that they all become training centers for KMC. After that, the district hospitals and other health facilities will be enrolled progressively, without forgetting the community KMC, which encourages referral of cases and follow-up of babies within the community. Of course, this demands a lot of investment. And in addition to the domestic investment that we're going to do, we'd really like to call on more those who are listening to us to join in this adventure, which has shown its success. I'm sure success will always come our way. Thank you.
Thank you so much, Martina, for your reflections. Yeah, thank you so much for joining us. That was really insightful. I'm now going to bring into the discussion Louise Saville, who will be presenting key findings from the end of programme report.
Thank you very much, everyone. It's a pleasure to be here today, and huge thanks to the Government Outcomes Lab for giving us this opportunity. My name is Louise. I'm a director in the international team at Social Finance, and I've been pleased to have been involved in the Cameroon Kangaroo Mothercare DIB from the very early stages of design right the way through to project end. So that's been hugely exciting, and it's great to have the opportunity to share some of our lessons today. As Hortense and Martina have mentioned, we're very proud of the results that this DIB has delivered. And I've been asked to talk a little bit today about what we learned specifically in terms of scaling and sustaining impact. So before we get into the lessons from the DIB, I just want to take a moment to reflect on what we mean by scaling and sustaining impact. Now, earlier this year, Social Finance took some time to reflect on what we've learned around this across our organisation from more than a decade of work to scale and sustain social change. And in April, we published a framework for thinking about building routes to scale, which was based on analysis of our own work and of other initiatives that have made significant progress towards or achieved impact at scale over the last 20 or 30 years. So our report, Changing Lives, Changing Systems, considers what we mean by impact at scale and also how we will know when we get there. And we quickly learned when we were undertaking that review that the reality of achieving impact at scale is really about weaving a number of different strategies together and building on what other actors are doing. Importantly, achieving such impact is the work of many hands. It's not going to be achieved by a single organisation or an initiative, even government. So we define impact at scale, as you can see on this slide, in terms of lasting change to people's lives, and particularly lasting change when products, services, or practices sustainably expand their reach. So that's really the context in which I'm going to be talking today, is thinking about what we mean by systems embedding change and/or society and culture shifting their perspective, and what we've learned from the Cameroon programme in terms of that. So first, let's just look briefly at the framework itself. And as I said, the end goal in our minds is about lasting change for people and society. And achieving this involves some combination of products, services, or practices expanding their reach, systems embedding that change, and society and culture potentially shifting their perspective. Then sitting below that, we identified some essential building blocks for lasting change. One was around widespread delivery of new services. One was around existing sectors adopting new ways of working. New and changed funding, we identified as often a key catalyst for sustained change, as well as supportive policies and legislation and potentially new public conversations. So let's switch now for a minute to think about how this applies to the Cameroon Kangaroo Mothercare DIB. More than any other impact one that I've been involved in, could we shift slide? The Cameroon KMC DIB aimed to create lasting change from the start. It's not coincidental that the first set of lessons I wanted to share today focus on the central role of the government of Cameroon across the life cycle of the DIB. So as Martina mentioned, government was at the table from the very early stages of the DIB design work, and also deployed significant funding from the Global Financing Facility at the World Bank to pay for programme outcomes. Having government at the table ensured that during the design stage, the programme responded to national priorities and plans around improving neonatal survival rates. It also enabled the government to ensure value for public money by testing the appropriateness of applying kangaroo mother care at scale whilst paying on the basis of results. During the delivery stage, the ministry also helped to resolve contextual and staffing challenges within programme hospitals. And as planning started a year or so ago for what comes next after the DIB, the ministry is really taking the lead in embedding kangaroo mother care in policies and planning, in clinical curricula, and in existing performance-based financing structures for hospitals and clinics as a mechanism to encourage ongoing use of kangaroo mother care. Now, before I move on, it would be fair to say there were some trade-offs in terms of timelines. I think looking at other development impact bonds that have launched in low and middle income countries, those that don't involve government so centrally have often moved through the design and contracting phases quicker. But I think, as you will see as we talk about what we expect to sustain, I think we would have lost a significant amount in terms of government engagement and support had we not had them at the table in that way. So how is the KMC DIB model designed? Well, it deliberately sought to embed kangaroo mother care capacity within the public health system in a sustainable way. So that meant empowering public sector hospitals, clinicians, and community health workers to deliver quality KMC. It meant embedding skills within the public system, the train-the-trainer model that Hortense mentioned, to ensure that new KMC clinicians can be trained and supported beyond the lifespan of the DIB. Hospitals were also supported to build the infrastructure and supply chains for KMC-related equipment and facilities that we hope will sustain for many years to come. We also aim to create a culture of moving beyond data collection to data-driven clinical practices. So clinicians were trained not only to deliver kangaroo mother care, but also to use the data to ask, who is the approach working for? What is driving the mothers that are discharging their babies against medical advice? Which babies are returning for follow-up appointments? Which caregivers are succeeding at providing extended skin-to-skin care? And that mindset, that adaptive data-driven mindset, enabled a kangaroo mother care model, which was originally based on a model developed for Colombia, to be adapted to different types of hospitals and different regions of Cameroon. So for instance, we fairly quickly realized that in order to overcome some of the logistical constraints in Cameroon around mothers needing to leave the neonatal ward to find their meals or to purchase medications, we needed to engage, for instance, multiple caregivers for each baby in order to get the duration of skin-to-skin contact in place. Hospitals were also tracking infant morbidity and mortality, patient throughput, and the revenues within each hospital to more broadly infer the impact of KMC and also to build the business case for continuing to offer kangaroo mother care within the neonatal practices beyond the end of the DIB. And as the DIB moved towards completion, the Fondation Kangaroo has focused on simplifying data capture tools for easier use by hospital staff, and also testing new ways of monitoring the delivery of kangaroo mother care that might fit an audit rather than evaluator-based performance-based finance framework. The DIB aimed also to create institution-based centres of excellence, essentially physical training and practice hubs within a smaller number of the programme hospitals. In reality, we found that this was harder to achieve due to COVID, clinical staff turnover, and non-DIB related infrastructure projects. But what was fantastic was that the programme pivoted such that it focused instead on creating communities of practice across kangaroo mother care trained clinicians in different hospitals, and ensuring a geographical distribution of KMC trainers across different regions of the country. So finally, we sought to create strong foundations for sustaining and scaling the impact of the DIB. And this has been a particular focus of all partners over the last 12 months. Thinking back to the foundations within the social finance routes to scale framework, Clarity of vision was absolutely key. And in this case, government's ambition that KMC is a core pillar of neonatal care in all hospitals and health centres in Cameroon. Sorry, Andrea, could we stay on the previous slide for a second? What that means is that Kangaroo mother care is being embedded in the National Strategic Plan for Maternal, Child and Newborn Health. And it's also being monitored and supported by a technical committee within the ministry. I mentioned earlier that impact at scale is a long journey and one that involves many partners. And the KMC DIB has laid the groundwork for national rollout of KMC in that way as well. So the ministry is now leading the prioritization and planning for the next phase of hospitals with support from the Fondation Kangaroo. However, the foundation has also been building a broader coalition of stakeholders around the Kangaroo mother care agenda, including UNICEF and others, with a view to ensuring that accountability and momentum is sustained. Finally, consistent funding is the third foundation on which impact at scale is built. It's hoped that government will fund infrastructure upgrades, clinician training, and ongoing support for new hospitals as the programme scales. And it's exciting that they're also considering hospital-level incentives to implement quality KMC within their existing performance-based financing framework for health system strengthening. So looking back then at the framework that I discussed at the start, skip slide now, please. The white blocks under the pink curve, and apologies, this looks horribly complex, but these slides will be available on the GoLab website after today's session. And this is really just a way of trying to visualize how we think about some of the building blocks of moving to impact at scale. And the white blocks under the pink curve indicate, I guess, the foundations and the strategic levers, the tools, if you like, that we attempted to use during the DIB, like funding and changing the funding, creating strong partnerships, designing a program that could have mass reach and was appropriate for the context, and using feedback loops and data for transparency and insight. The white blocks above the pink line represent a number of the ways that government is now thinking about delivering impact at scale following the DIB. So expanding solution delivery, really embedding and adopting Kangaroo mother care protocols and curricula within core government processes, and continuing to create accountability through specialist committees and coalitions of interest. Now, time will tell whether, in fact, the KMC as an approach will sustainably expand its reach in Cameroon, and the programme officially comes to an end tomorrow. We will find out in time whether government and hospital systems sustainably embed data-driven accountability and adaptation processes. But what's really exciting is that the ambition is there, and there is reason to be hopeful that the DIB could have stimulated sustained impact at scale. But in the meantime, in the lives of the families and those of over 1,000 others in Cameroon have been immeasurably changed by, during the course of the DIB, having low birth weight and preterm babies that not only survived but thrived. That's a huge credit to all of the neonatal clinicians, foundation and government staff that have worked so hard on the DIB over the last 2.5 years. And it's been a pleasure and a privilege to be part of the team that made it happen. Thank you.
Great, thanks so much, Louise, for sharing such a rich set of findings with us. And yeah, I really do encourage anyone to read the end of programme report. It really is an interesting set of findings and a great project. We've got a couple minutes so we can move on before we move on to the panel discussion. We've had a couple questions in the chat come in. I know that there is Can from Turkey who asked a couple questions. Can, would you like to take yourself off mute and ask the questions to our presenters today?
Sure. Thank you for the opportunity. I'm joining actually to learn lessons as we try to promote SIBs and DIBs in Turkey. We don't have any, and we have a lot of social issues that could be suitable for SIBs and DIBs. And as we try to promote them, one of the biggest challenges that we face is how do we initiate the idea? I myself am I'm an impact investor, and I'm trying to work with government, with service providers, with impact investors, with outcome funders. But I was curious to learn more about how the idea came about. I think, from what I understand, it actually was initiated from the government side, but any lessons learned, any recommendations on how to bring the different partners together, how to motivate them in a place where there hasn't been an impact bond before?
Thanks very much, Cam. Would anyone like to take that?
So to some extent, I can talk a little bit about this, but it was a joint effort, I think. As with most outcomes contracts, they are really a partnership in the most literal sense of the word. So the starting point for this program, or at least the conceptualization of it as a development impact bond, really came about by some early work to review Grand Challenges Canada's grant portfolio, to think about where there might be potential to sustain and scale impact, and where there might be an outcomes-based approach that could be helpful. And GCC had funded KMC and had supported the development of an evidence base linking, if you like, the impact on infant morbidity and mortality with I guess, very clear process markers, which around what quality KMC practice looked like, which meant there was a really nice kind of basis for doing this. And then Carolina, you may want to talk a little bit about how then government was brought into the process, because they really were a key partner, I think, quite early on.
Yeah, happy to jump in here. So yeah, the government, because we had done a pilot study or a pilot project after our Columbia grant to do the study on KMC, the government was involved early on in the early stages of the evidence generation within Cameroon, and we saw a lot of success within Cameroon, and Martine and her team were very engaged right from the start, and it seemed like a really it seemed like the right partnership to pursue further, because we were working in Mali and Cameroon at the same time to test KMC in new geographies beyond Colombia through the Kangaroo Foundation network. And so that's really how that partnership kind of evolved, is really through that initial evidence generation, and then bringing that evidence over to the Ministry of Public Health and gaining their trust and understanding of what KMC, there is valid evidence on the ground to show that it works. And from there, the discussions started to progress, and hopefully that answers some of your questions.
Yeah, thank you very much.
Maybe in addition to what Louise and Carolina have said, we had this problem, with we still have of newborn mortality, and within the in our initiating the investment case within the global financing facility, we insisted on the need to reduce newborn mortality. So, and we had money available for this $2 million US, and we wanted to do everything to make sure that this money would produce the results. So the idea of using the money after attaining the results was really very, very attractive to us. So yes, it was easy for us to join the bandwagon, and we made sure that we stayed there until the end.
Thank you.
Thank you so much, Carolina, Martina, and Louise, for that. And thank you, Can, as well. I see we've got a couple more questions coming in on the chat. I know we've got a really insightful panel discussion coming up in which we'll be able to integrate a lot of these questions. So I'm going to pass on now to my colleague, Andrea Anastasio, for the next part of our panel discussion. Thanks so much again, all, for presenting today.
Great. Thanks so much, Laura, and huge thanks to Louise, Hortense, and Martina for the really rich presentations and discussions. And hello from Oxford, everyone. I'm Andrea Anastasio, and I'm a Policy and Engagement Manager within the Government Outcomes Lab. So it's my huge pleasure to facilitate the next part of our discussion, which will be a panel discussion where we're inviting, alongside Louise, Martina, and Hortense, 3 other experts. So we'll have Carolina from Grand Challenges Canada, our very own Mara Rolde, the director of the Government Outcomes Lab, and Thomas Kenyon, a senior economist at the World Bank. We really want this part of the session to be really interactive, so please do keep asking your questions in the chat. We'll stop throughout to hear from our audience. We'll ask you to unmute yourselves if you want to ask a question or just share some reflections. But just to make sure we have a little bit of structure to the discussion, we're proposing 3 core themes that we want to explore with our guest panelists. One is around how do you actually design a DIB program with sustainability in mind, and we've heard a little bit from Martina and Hortense and Louise on this, but really we want to see what are some of the lessons and broader applicability that we can lift from the Cameroon experience and apply to other projects. We then want to look at some of the routes to scale. Louise explained a little bit, and so did Martina, around how the Cameroon Ministry of Public Health are thinking about embedding the Kangaroo mother care intervention within their national policy, but there might well be other routes to impact. So we want to explore some of those. And finally, if we're talking about scaling impact, we want to explore a little bit what that looks like in practice. What are the trade-offs? What are some of the challenges that practitioners might encounter as they look to scale impact? So without further ado, I will ask Carolina, then Mara, and then Tom to just briefly introduce themselves. Please do give us an overview of your work and the perspective you'll be bringing to the discussion. And after the brief introductions, we'll dive straight into the discussion. So Carolina, over to you first.
Great, thank you. I'm Carolina Kwok, Senior Portfolio Manager at Grand Challenges Canada. And in the context of this discussion today, I'll be providing a bit of an investor perspective, as I have been leading the file here at Grand Challenges Canada, overseeing the Kangaroo Mother Care DIB. I also oversee our maternal newborn child health portfolio, and looking forward to the discussion.
Thanks, Carolina. Great to have you. Mara, can we come to you next, please?
Of course, I'm Mara Iroldi. I'm the Academic Director of the Government Outcomes Lab. And the perspective I bring today is the perspective of an academic. At the Go Lab, we are engaged researchers, and so we bring a fresh view, a critical view in the sense of applying critical lenses on the experience that we see. And we are really interested in teasing out lessons that are relevant beyond the particular case. So the lens I bring is this learning lens, taking a step back and thinking, what is it that we want to learn from this experience for other stakeholders.
Great, thank you, Mara, for joining us today. And last but not least, Tom, could we come to you, please?
Sure, thanks very much. Pleasure to be here. I'm Tom Kenyon. I'm a senior economist at the World Bank in Washington, DC, now in the operations policy unit of the bank, where I'm responsible for overseeing our results-based financing instruments, particularly the program for results instrument, which I'll say a bit about later. Before that, I led results-based financing operations in Brazil and elsewhere. So I bring the perspective of someone who's done this as a task team leader for about 6 or 7 years. And then more recently, someone who's involved in evaluating the effectiveness of these types of operations. Thanks.
Super, thanks so much, Tom. It's great to have a non-DIB perspective, and looking forward to hearing more about your experience with results-based financing. Right, so just to kick off the discussion, Laura, perhaps could I ask you first to spotlight all of our lovely panelists? And while you do that, I'd like to go to Mara first. So we've mentioned scaling impact quite a lot already. And I know as an academic center, we love definitions, we love clarity. I think there's a little bit of a distinction that we need to make between scaling impact of a particular program or intervention and scaling the DIB, the impact bond, as the mechanism through which an intervention is funded. And I think as a lot of people on the call will recognize, I think sometimes the two can get conflated. And, similarly, when we're talking about sustainability, how do we differentiate? How do we draw the lines between the two? Enlighten us, Mara. I know we've been doing a lot of thinking about the distinction and kind of why it's really important to separate between the two.
Yeah, sorry, this is just to frame the discussion, because for the audience, at our webinar, often we talk about what is it in a outcome-based approach, in an impact bonds, that what is it that it brings that is different, and when is appropriate, can it be scaled as a way of working? And in part, the question asked by Can in Turkey today signal an interest in the financing mechanism and what it brings to the table. But I think it's important to be clear that today the discussion is about once you have an intervention that has an evidence base, like the Kangaroo mother care, and you are trying to apply it to a different context. We saw before it was developed in a different context in Colombia, and now we're trying to roll it out somewhere else. The world is full of evidence-based intervention that have a strong evidence of effectiveness, and the intervention worked there and then. But the question when you roll out something is, will it work here now? And the context is different. In this case, the healthcare infrastructure is slightly different. It might not be rolled out in the same type of clinic, and the preparation of frontline staff is different. Will the intervention still be effective? And so what the Kangaroo Mother Care DIB tried to do is to test, is this evidence-based intervention able to adapt and deploy core mechanism given the different healthcare context and system. So the focus of today is once you move away from the pilot, from the experimental intervention, how can we ensure this adaptation? What can we learn from this adaptation? And so this is the focus of discussion today. And I just want to avoid confusion, because often with our audience, we talk about having an outcome focus and having access to different type of funding. But this is not what we're talking about today. Is from in principle pilot, can you roll out a particular intervention when the context is different?
Great, super. Thanks so much, Mara. And then just staying on this point about sustainability, Louise, I think you've already touched upon this a little bit when Khan was asking about actually how do you got the DIB off the ground in the first place? How was the conversation with the government initiated? We know that it's really difficult to even get engagement from government, get buy-in, get that ownership. So I'd love to hear both from Louise and Martina just a little bit more about what have been the secret ingredients that have meant that this particular project is so successful. And Louise, I know you have years and years and years of experience working on impact bonds. What's felt different in this case, and how was the approach to sustainability perhaps different compared to other impact bonds that you've seen or worked on? So perhaps Louise, could we come to you first, and then I'll go to Martina.
Oh, thanks, Andrea. It's a really great question, and I think some of this actually speaks to I think the importance of being really clear when you're using an outcomes-based contract, be it an impact bond or otherwise, about ultimately what it is that you're trying to achieve. And I think that varies quite a lot, and that's fine that varies. But I think what was very clear very early on in working with government here is that what they really wanted to achieve from the DIB was a model of Kangaroo mother care, this very well evidenced intervention from other contexts that would specifically work across a number of different types of hospital in Cameroon. So some of the hospitals in the program were big urban sort of centers of excellence, and some were much more basic, district hospitals serving a mostly rural community. And I think what was really fun about the flexibility that an outcomes-based contract gave us was we were really able to, or Hortense and her team were really able to test and adapt and refine models of Kangaroo mother care that worked across a whole range of different contexts for Cameroon, and specifically worked with the ambition that after the DIB, knowing that this might be something government would want to take to scale nationwide, and therefore needing to have those variants developed within the system. But really, Martina and Hortense can talk about the reality of achieving that.
Okay, let me come in here. I think in addition to what Louise just said, it took for us in Cameroon to convince the other colleagues, because of course we had to work. This was money, $2 million US that we got, from the GFF, and of course the ministry in charge of economy, finance had to be associated, to how these funds will be used. I think what made them, what made it work for us, for the other colleagues in the other ministries to accept our proposal of using this approach, was the fact that we were able to clearly state what our problem was, too many babies dying, and the fact that this money will only be used after we have achieved results. So to me, that was really the key that really got our colleagues in other ministries to accept Cameroon engaging in the DIB approach. I think that's what I can add at this stage.
Martina, thanks so much for that. And thank you, Louise. Martina, if I can stay onto you for another moment, I'm just really curious, and how easy or otherwise was it for you to engage with your colleagues and to get that buy-in? At the Government Outcomes Lab, we spend a lot of time thinking about how to consolidate the capacity of government civil servants to engage meaningfully with outcomes-based contracting. And that sometimes can be a challenge. So I'm just wondering, within the Ministry of Public Health in Cameroon, do you feel that, the skills and understanding of the model itself was already there? Did you have to do a lot of work to get your colleagues to operate at as an informed, refined outcome funder?
No, the thing in the Ministry of Health, before we got to this stage of the DIB, Cameroon has been involved in performance-based financing for the past 4 to 5 years. So this was like exactly the same thing, but based on one specific intervention. So the fact that for those of us in the Ministry of Health, the fact that we have been carrying out performance-based financing for other interventions, really helped people to understand. The people that we now had to convince were the ones in the other ministries. And then, of course, we either had to do that or we use the normal project funding mechanism where you put in, you go in with inputs, and we all know how unsure it is that, we'll attain results. When you have to train staff, buy equipment. First of all, for example, in my country, purchasing equipment takes, a lot of money, because you have to pay taxes, you have to make sure that, you choose the right bidder who will provide the equipment. So people see it as a means of economizing the funds that we had received from the GFF. Yeah. So already being in performance-based financing helped a lot to get people to understand what we wanted to do. Over.
Super, thanks, Martina. Hortense, do let me know if you want to jump in at this point. Otherwise, I will invite Carolina to share more on the investors' take perspective on these questions of sustainability.
Sure, Andrea. So, at GCC, we are really kind of a transition to scale in a funder usually. So we really look for proven evidence-based innovations and provide funds, usually in the form of grants, especially in the maternal newborn health space, to innovators to start to scale their project. And this KMC opportunity really came up because we were so engaged with the initial evidence generation, as I mentioned earlier. And as an innovation platform, we were open to trying new things. And one of the new ways we thought we could engage was through an innovative financing mechanism, through a DIB. It wasn't an easy feat, I think, to get through to our board and our investment committee. It required a lot of support from experts like the Mars Center for Impact Investing and Social Finance to really set up and build the argument of why this was a worthy investment in this mechanism. And that process took about 3 years to even finalize, and through a lot of changes in where GCC would be, as we came as an outcomes funder at first and then switched to an investor role once some stakeholder changes were made. So as an investor, we really had to be very flexible in understanding kind of during the design phase what needed to be done, given we were really passionate about scaling this innovation in some way. I think in terms of embedding sustainability, I think we were so fortunate to work with the MOPH right from the start, because the ultimate innovation itself, KMC, is for mothers and babies that are usually accessing public sector hospitals. And so the government engagement would enable us to more confidently say that this practice can be embedded in normal routine practice at these public sector hospitals as well. And so really that key point on sustainability is securing the right partners at the table right from the start. And so we were fortunate to engage with MOPH and GFF. And then the other aspect that we wanted to pick to factor in was also choosing the right technical partner to implement, because GCC, we don't implement at all. We're usually a very hands-off in donor. And so choosing a technical partner like Kangaroo Foundation, who has a lot of experience delivering this care and training clinicians, which is ultimately kind of the model that we wanted to replicate, was really the right partner for us as well in terms of rolling out and training other trainers within Cameroon. The other thing that we wanted to factor in when we think about sustainability was also ensuring that there was a strong governance team to support these sustainability discussions and considerations right from the start. So having a strong technical committee to support elements of project implementation, which was also overseen by our project board, and having a steering committee that also provides more contractual changes, allowing more contractual changes, was really crucial. And I think all of these three committees really work together well to ensure certain elements could support ongoing sustainability. For example, there was some discussion about turnover at the beginning, which really affected the sustainability and quality of KMC being delivered at the hospitals. And I think some agreement with, after lengthy discussions, and Hortense and Martina, you can step in here at some point, really work to try to minimize this amount of turnover in areas where they deliver KMC. And that really helps with sustainability down the road. I'll pause there. I'm not sure if there's anything Martina or Hortense you want to add.
No, there just loads in that response. Thanks so much, Carolina. That's really, really interesting. So I'm hearing a lot about the fact that, that flexibility, governance arrangements, a data-driven approach have been absolutely key in the success of the DIB. And Hortense, I'm just really curious, as you're looking at this transition from SIB to sort of nationwide or wider implementation, how is the Kangaroo Foundation or the provider organization thinking about how do you maintain that, these secret active magic ingredients that you see within a DIB? How do you maintain them, preserve them outside that context? And Hortense, I'd like to come to you for that, but if any of the other panelists want to chip in, please do so.
All right, so for us during the last 10 months, like Louise was said earlier, of the program delivery, we have been working with the government when we look to talk about sustainability, because it was key for us that we don't stop at this point. So because the government was with us, as we've said earlier, during the contracting and implementation, we were able to share what we have learned. So as part of this, the agreement that we have at this point, and this is in discussion, is the fact that the Kangaroo Foundation will continue to play the key role of accompanying these hospitals in terms of the quality of the kind of delivery that is being that we are seeing in the hospitals, as well as playing a key role of enrolling new hospitals. So what we are seeing is that while we have trainers in the different hospitals, these trainers cannot do it on their own to deliver the kind of quality that we're talking about. So we thought that initially, as we look at the scale of KMC in Cameroon, the government of Cameroon still feels that the Kangaroo Foundation will continue to play a key role. Of course, not as much as it was in the beginning in terms of the KMC DIB, but more in terms of really having the data, looking at the data, and making sure that this is a data-driven process. So we've had a more simplified data collection tool that will still enable the foundation to be able to look at the insights on this data and provide this technical advice to the government to say, this data is changing either positively or negatively. We think that this could be some of the ways in which we can improve that. So this is how we are looking at sustainability as a foundation. We are looking at how we make sure that we sustain the hospitals that are already on the program, how we make sure that we accompany the government to scale. And this, of course, the foundation is looking at going even beyond the context of Cameroon. And the focus is the same. How do we make sure that the foundation continues to play its role, which is, of course, this is where the skills and the expertise of the foundation really lie in training and monitoring and accompanying this clinical team. So that is the role of the foundation going forward. And we are really happy to see that the ministry still looks at the foundation really with that perspective. And we think that this is one of the great ways in which we'll be able to sustain the kind of quality that is required to get the results that we expect from KMC as a practice.
Right, that's really interesting. Thanks, Hortense. So it sounds like an ongoing ethos of working in partnership with government will be really important. Martina, was that a hand up? Did you want to chip in?
Yes, just to say, in addition to what Hortense has very well articulated, that to really make that a reality, the Ministry of Health recently signed a framework convention agreement with the foundation, because to us, the foundation is really going to remain that technical partner that should accompany us using our personal funds or any other funds that any other partner would invest. Yes, so a framework convention has been signed between the ministry and the foundation of late.
Thanks, Martina. Tom, can I turn to you now? It'd be great to hear more about the work that the World Bank is doing as part of its Program for Results Financing initiative. I'm really curious, as someone who is not directly involved in impact bonds, but with a really good understanding of the model, what are your reflections, any helpful insights and lessons learned from your experience working on the Program for Results initiative?
Sure, thanks very much. So, I mean, the program results lending instrument is motivated by two ideas. And the first is the one that Mara mentioned and that you're familiar with, which is that by paying out against results rather than inputs, you draw attention to things that matter and perhaps give governments more flexibility in how they're achieved. But the second part of this approach, which I think speaks to the question that we're involved with here, is that it makes more sense to use a country's own systems for managing project risks, for managing fiduciary risks, for managing environmental and social risks, rather than to insist that they use ours or some other donors. And there's been a long evolution to this. I mean, the World Bank started out in the 1950s, financing infrastructure projects like dams, roads, and pipelines, and paying out against expenditures, basically financing contracts. And then in the 1980s, as you're probably aware, we did a lot of structural adjustment lending, rewarding governments for changes in policies and compensating them for any associated revenue losses. And these two approaches are still there, but it's become clear over the last 20, 30 years that this isn't enough. You can finance the construction of new roads, schools, and hospitals, but you need to ensure that people are paid on time. You need to ensure that they're trained. You need to ensure an appropriate level of service delivery, both in terms of quality and reliability. So you also need to think about financing operating expenditures. And you need to think about the systems that underpin the delivery of those services. So we started moving away from financing specific contracts or transactions and more to supporting ongoing programs. And we also began paying more attention to fixing bottlenecks in procurement systems, in financial management systems, and in other social and environmental risk management systems. And so this led us to introduce about 10 years ago, this P4R instrument, which now accounts for about 15–20% of overall World Bank lending. And actually, I think it's about 80% of all donor-based, results-based financing. From what we can tell, it's about 18 billion in all. So that's a bit of background. I mean, I'll say a little bit about the experience of attempting to strengthen these management systems in a little bit later on when we talk more specifically about scaling. Thanks.
Yeah, bro. Yeah, we'll come on to that in a second. Thanks, Tom. I would like to now take the discussion onto the second theme that we wanted to explore, which is around the routes to scale. But before I do that, I'd love to check with our audience if there are any questions that they would like to ask of any of our panelists, or indeed any reflections from your own work that you'd like to share. Do raise your hand or drop a message in the chat if you want to chip in. Okay, I'm not seeing any raised hands. So with that, I'd like to go back to Louise and Martina for a bit more of an exploration on the way that the Cameroonian government, I guess building on the experience of the DIB, went about thinking the different options and routes to scale. So Louise, in your presentation, you were explaining how from your own experience at a social finance, there are different routes, different processes, usually of combination and multiple approaches that you're looking at when you're trying to scale impact. So my first question is for Martina. I'd just love to know what the thought process, the decision-making process has been within the Cameroonian government. Why did you choose the route you have in terms of scaling impact, and what were some of the key considerations?
Okay, thank you. First of all, as Hortense just said a while ago, we have to make sure that the 10 hospitals where this is happening, they continue benefiting from close follow-up, so that what we have achieved there doesn't die down, because that happens with many projects where we work just during the project duration, and then we stay up. So first of all, ensure that the 10 hospitals continue the work they are doing, and some of them will serve as training sites for the others. Secondly, these 10 hospitals, I would say, are in 5 of the country's 10 regions. Newborn mortality is a nationwide problem. So we have to make sure that all the regions do have at least a hospital, a referral hospital, where we can embed KMC and allow that structure serve as a reference or a training site for all the subnational or the lower hospitals, like the district hospitals and the health centers. So that's the very first thing that we're going to do, make sure that we have a hospital in each region that will continue the work. A problem was mentioned a while ago about the excessive turnover of staff. We noted that as a challenge. If you really have to scale up something and make sure that the hospitals where this is happening continue doing so, make sure you don't post the staff out of the place very often. So that one is going to be looked at closely. Then of course, this takes we have to go gradually, because there's quite some investment to be done. Our towns can see how much was invested in the 10 hospitals to be able to for them to be where they are today. So as I said, we are counting on our domestic funding, but also hopefully UNICEF and others will support in this. Basically, we have to make sure that we continue supervision, and this supervision, in my opinion, should actually be carried out. Yes, the foundation is there, but we now have this group of trainers that have been trained. So we are going to make out of those trainers a team, a community of KMC leaders who would actually be the ones to, as much as possible, make sure that KMC is being carried out in these hospitals as it was meant to be, quality KMC. Hopefully with close supervision and then more investment in terms of financing, we should be able to scale up gradually and surely in these hospitals. It sounds easy, but it's not going to be easy, but we really want to do that, to be able to reduce newborn mortality.
It sounds really challenging, actually, Martina, but what a worthwhile ambition. Hortense, I know you work very closely with the Ministry of Public Health in helping them refine their plans. Was there anything else that you wanted to add to Martina's contribution?
So if I were to add to Martina's contribution, the big thing for me is that the government is willing. So that is the very first step. So we're very happy to see a government that is willing. But also we think that the government, we are in the process of navigating, of putting through some of the Kangaroo mother care specific indicators into the performance-based financing system that is already ongoing. So two things that this would help us do is one, to continue to monitor progress in terms of Kangaroo mother care, but secondly, it's also a means of incentivizing the staff and the rest of the hospitals to make sure that they continuously deliver the quality of the care that is required. This, of course, the performance-based financing is in partnership with the World Bank, and we're getting the World Bank into the conversation. I can see Tom nodding. And we really hope that there are some hospitals that do not have Kangaroo mother care units now, but we think that if it becomes part of the performance-based financing mechanism, it could also be a prompter to some of the hospitals to actually pre-invest, with the hope that based on what they get from the incentive that they get from the PBF system, it could generate some more income for the hospital. So these are some of the ways in which we're working with the government to make sure that this happens. So the Kangaroo mother care indicators will be on the National Information System. We also hope that that would also, as soon as possible, integrate these Kangaroo mother care specific indicators within the PBF system. So as we speak now, we don't have specific KMC indicators. We have quite a limited number of actually neonatal health indicators. So we are talking with the team. It's been facilitated, of course, from the technical department, but also the World Bank is part of this conversation. And yeah, these are some of the efforts that the government has made to demonstrate their keen interest in making sure that this is sustained.
Great, thanks, Hortense. So this point about the importance of the active engagement from government partners keeps coming up. Louise, you'll know very well that that's not always the case. So I wonder whether our participants today might be wondering, well, okay, but if we're not fortunate enough to have that level of government engagement, or it's just simply not feasible to have our program or intervention commissioned as a nationwide program, what are some of the other routes that organizations can be might be looking at when they're talking about scaling their impact? Can I come to you for some reflections on that, obviously from the world of impact bonds, but perhaps beyond as well?
Yeah, so I think there are obviously a number of actors, I think, other than governments, that are interested in either outcomes-based contracting per se, or embedding an outcomes mindset, if you like, into their programming. And those include philanthropies. They also include some of the more institutional donor agencies like FCDO or USAID and others. So I think while it's ideal to have government at the table from a kind of system change and embedding change point of view, I think there are often ways to get programs off the ground and scaling without that. I think sort of reflecting on what we've seen and what's important, I guess, as foundations for impact at scale, I think some of the things that are core components of outcomes contracts and impact bonds are also core components of achieving that scale outside those structures. So things like having really engaged multi-stakeholder, often cross-sector governance and accountability processes. Things like having a really clear and agreed definition of what it means to, what does success look like? Having a real agreement around that, and not just agreement, but also metrics that enable you to track progress against that objective, I think is really important. Linked to that, I think having data models that work, having consistent data capture, having data-driven decision-making processes, whether involving government or involving other stakeholders, is really important as a way to monitor progress and also inform adaptation and improvement. And I think the other thing we're seeing is all different kinds of stakeholders, sometimes top-down, sometimes bottom-up, pushing for a little bit more flexibility in their contracts. So even if they're not explicitly outcomes based, pushing towards structures that have a little bit more contractual flexibility, maybe a little less tightly defined around specific activities and specific timeframes, and a little bit more based around some of the more relational principles around decision-making structures, metrics of progress, and essentially allowing some adaptation based on that, whether full or whether within certain parameters. I think those are all ways that we're seeing stakeholders start to embed an outcomes approach beyond simply the framing of an outcomes contract itself.
Great, thanks for that, Louise. It's really helpful. Got about 15 minutes left together, so just a reminder to our online participants to continue asking their questions if they have any for our panelists. Tom, could we come back to you now, please? It'd be great to hear more. You've mentioned some of the enabling factors a bit earlier on. It'd be great to get you to elaborate a little bit more on that in terms of how the World Bank is working with in-country partners.
Sure, of course. So moving from interventions to programs and scale requires us, I think, to think first much more about the various actors in the service delivery chain. It's not just line ministries and service providers, but it's the whole machinery of government behind them, ministries of finance, planning, and budgeting in particular. And we also need to think about the systems used by those actors for monitoring results, allocating resources, and ensuring that they're spent effectively. So we're thinking about things like financial management and procurement as well. And it means being more attentive to who needs to do what in this chain, and ensuring that they have the resources, information, and motivation to do it. So one component of this is what Louise was talking about, which is what we might think of as a results-based management system. And this involves strengthening the monitoring and collection of data, the use of data, incentives for achieving results, both within line ministries or sector agencies and between them and ministries of finance. And you want to think of this as a sort of cascading set of accountability relationships across different levels of government and within levels of government. And then you probably want to think about some element of encouraging flexible problem solving or adaptive management. And the evidence from what we've seen so far is that there are some features of at least our program for results instrument and results-based financing more generally, which predispose themselves to strengthening these systems. I mean, the requirement that we have for independent verification, for example, of disbursement linked results means that we're getting much more timely and reliable data on what is actually being achieved. But there's much less evidence of impact on the use of data for performance management or on incentives facing staff within line ministries. This tends to be seen as something that's inherently political, and we really haven't got into it very much. Nor is there very much evidence of flexible implementation. And this may just be the way that the World Bank works, but our counterparts in government have also tended, I think, to see it more as a tool for enforcing accountability downwards and disciplining poor performers than they have for decentralizing problem solving or extending responsibility to frontline service providers. And working with government systems for financial management, procurement, and human resources is also very difficult. I mean, we know from history that this is a continuous long-term process. I mean, it took what we think of as developed economies about 200 years to develop, reliable budgetary systems, and they're still evolving, or in some cases going backwards. We also know that technology adoption is not enough. It's not enough just to buy a financial management information system or set up an e-procurement system. I mean, you've got to make sure that people see an interest in using it and that their behavior is changed as a result. And it's inherently political. Reforming procurement systems or introducing controls on financial management can threaten opportunities for rent seeking, it threatens discretion or limits discretionary decision making. And there's actually very little even academic literature or hard evidence on what works. I think partly because these are sensitive areas of government and very few have been willing to open up to outside scrutiny. And so our record on this actually, has been a bit mixed. We have about 10% of our disbursements which relate directly to financial management and procurement, mainly for the acquisition or deployment of systems. And these are things like digital payments, e-procurement, framework agreements for procurement, which might apply to medicines in your cases. Or financial management systems, particularly for making sure that payments flow on time to hospitals and frontline service providers. But it's very difficult for us to assess whether this is working. We are not ourselves collecting data on things like rates of budget execution, on delays in funds flow, on transparency or timeliness of procurement processes. And I think this is partly because we come with a compliance mindset, but also because the governments themselves are sometimes very reluctant to open up and allow us to evaluate properly whether what we're doing is working. Thanks.
Tom, thanks for that very honest overview of some of the lessons that you've drawn from your experience. Mara, we know that scaling innovation is never easy. We know that from practice. There's a lot of research, I guess, in implementation science that points to that. And just because some things work really well at a small scale within a pilot, that doesn't necessarily mean that it will have the same results when you try to roll it out at scale. Can I bring you in? It'd be great to maybe hear from some examples from the UK and beyond around some of these. We've heard a lot about enabling factors, but what are some of the pitfalls that we need to avoid, things that we need to keep in mind as we're looking at scaling impacts?
Thank you, Andrea. Yes, I think there is a lot of literature on implementation and implementation failures. So we often have ideas, especially in healthcare, where you have some clinical research that shows that particular intervention or treatment is very effective. And then it becomes mainstream. It's like, oh, now we'll prescribe this medication, we'll prescribe this treatment to the whole population. And what happens is that in the pilot, in the study, usually you work with the best possible medical team. You have a lot of resources. There is intensive monitoring because we have to demonstrate it. And so you have all this attention, and we think that is the intervention that does everything. No, the people who were involved, the resources, the attention to data and keeping track, that played a fundamental role probably in the success of the intervention. But then you prove the success and you decide, let's make it national policy and you roll it out. And that often happens over and over again, and it's called implementation failure. But it's a badly designed implementation. And actually, I think what is interesting of this particular DIB is that they did this intermediate step and say, oh, there is an intervention that worked in a place. If you want to roll it out, what can go wrong? And there was some thinking through. I have two examples that I would like to bring up from the UK where there was something that seemed to work. And I'm talking to our audience of people who have been looking at impact bonds in particular that we know very closely. And one is the very first famous Pittsburgh social impact bond to support young prisoners. And the idea was to support young men on short-term sentences before release and after release in terms of training, vocational education, helping them with building their confidence so they can rejoin the workforce and society as productive member of society. And the impact bond was very successful. And when the Ministry of Justice decided to roll it out, they said, oh, we are rolling out this a successful intervention. They send it out to procurement, like, oh, let's offer support to these young men in prison and just after release. It was massively underfunded. And the expectation on the service was super high. And nobody was responsible for the quality of the service being delivered to program participants. And guess what? It was a massive failure, but it was a failure by design. And we have now another one that is cooking up in the UK, and I venture a prediction. So we have various pilot of social prescribing. This is offering a link worker that can support people with complex need to identify like tailor support for their complex need. And a lot of it is try to identify which services they can access, when, and there is a lot of signposting. And there is this large impact bonds called Waste to Wellness that try to pilot this approach and make the case for putting a link worker in family practices to support people with complex need to navigate the system and what is available. Again, they just completed, it seemed to have been a massive success. And already a couple of years ago, the government announced that social prescribing is national policy. And by 2023, everybody in the UK should have access to this intervention. But the caseload of these link workers in the rollout is super high. So the magic dust of this intervention seemed to be the personal relationship that these link workers managed to establish with program participants. There was trust, there was an understanding of what were your needs, and this depth of relationship you can't build if you have twice as many people to see. And now social prescribing in the rollout is seen as signposting. An algorithm can do signposting. The magic was the relationship. So I think very often we have this approach that seem to work when all the resources go to it. And when we roll out, then the numbers get big, they're underfunded, and then it seems they don't work at scale. So I think we need to build on these lessons. And I thought what is interesting of this particular DIB is that it did this middle step. It said, Kangaroo Mother Care worked in Colombia in a particular setting. Before we roll it out to national policy, can we just test the water and see what are the key mechanisms? So to me, try to understand what are the key mechanisms is fundamental. And those are the ones we need to protect in the implementation, not a book that says like, oh, this is how the intervention works, because the people involved and the resources you put in is fundamental. And so you need to see like, what do I need to protect? If resources are less, if the attention is reduced, still, what is the key ingredient?
That's really excellent. Thank you, Mara, for putting this discussion into a wider context. I found it really helpful. We are unfortunately almost at time. I don't know whether any of our fellow panelists want to add anything else to Mara's response. I see people nodding. Otherwise, we always like these sessions to be as practical as possible. So before we say goodbye, I'd like to invite each one of our panelists to share with our audience one top recommendation, top tip from their work and their experience around effective ways to go about scaling impact. A big question, I know, and you each get about 30 seconds for that, but you know, if there's one thing you really want to pass on to fellow policymakers, funders, practitioners, what would that be? And you know, just on the order on my screen, actually, Mara, Carolina, Tom, and then Louise, Martina, and Hortense.
Well, I'll be super quick. I think you really need to spend time to identify what is the key mechanism in the intervention. And when you roll out, that is the thing you need to protect and focus on, and let the other things go. Focus on the key mechanism. Be very clear what it is.
Sweet and short. Thanks, Mara. Carolina.
I think many people mentioned this as flexibility as an investor. I think that's a crucial part. Because learning is a constant within these types of projects, and sometimes what we design isn't necessarily reflective of realities on the ground. So flexibility is key.
Cool. Thanks, Carolina. Tom, and then Louise.
I'm just going to repeat what Mara said, which is to think very carefully about who needs to do what in the entire service delivery chain, and whether they have the resources, financial level, information, and motivation to do it. Thanks.
That's a great one. Thanks, Tom. Louise, then Martina.
Yeah, I think mine is similarly short, which is be really clear about what you're trying to achieve when you're designing a program, not just within the period of the program, but also beyond. And I think being clear about that from the start is so important in ensuring that you're set up for success in terms of sustaining impact in the longer term.
Thanks, Louise. Martina?
For my part, of course, you would imagine, I mean, we've all agreed to the fact that governments are not that fast to react for several reasons. But if you want sustainability, if you want to scale up, they have to be at the center of everything. So it's good to be patient, in addition to what all the others have said, flexibility, but also patience, so that what we invest actually produces, because we've had that patience to really move along and even inspire the government. Thank you.
And thanks, Martina. And Hortense?
Yes, bits and pieces have been said already, but my big take would be, if we want the change that we want, we should be working within the system that we want to see the change in. So in this case, working within the public service was quite important, was key. And that is why, because it's in the public service that we want to see the change in the long run. So if we work in the different system, the private sector with the private hospitals, we might not have the change that we want. So yes, accountability, working with within the system, and of course that would involve the Ministry of Public Health in this case. Of course, accountability counts, and just like the rest of the different panelists, flexibility.
Brilliant. 6 really powerful recommendations. Huge thanks to our incredible panelists this afternoon. And huge thanks to our audience for all the questions, all the reflections shared on the chat. With that, all that's left for me to do is to, again, just huge thanks, everyone, and invite you to join us next month for our next session in the series. Bye, everyone.
Hi.
Thank you.
Thank you. Wonderful session.
Thank you, everyone. Bye.
Thanks very much.
Bye.